Hello everyone, greeting from Spain. We are excited to present our work regarding the influence of ophthalmological background on the side effects of overactive bladder treatment during the first ever ICS online meeting. I have no disclosures. It is advisable to consider ophthalmological disorders in women with overactive bladder before the administration of pharmacological treatment in order to avoid iatrogenesis in ocular pathology. The objective of our study was to describe the risk of dry eye or de novo conjunctivitis with different overactive bladder treatment in women. This is a retrospective multicenter observational study of 1,003 patients treated for overactive bladder and who had at least an ophthalmological review in the previous year. Patients with amaurosis, amblyopia, and retinal pathology were excluded. The variables studied were age, body mass index, evolution time, ASC score, secondary diagnosis, and eye health evolution. The patients were grouped according to their ophthalmological background, differentiating patients with non-glaucoma, patients without ocular pathology, and those with glaucoma. Different treatments were analyzed, include Botox, fesoterodine, mirabegron, oxybutynin, pelvic floor muscle training, solifenacin, and tolterodine. The mean age of the sample was 64 years old, with a range from 19 to 85. Patients without ocular pathology were younger. More than a half of the patients previously diagnosed with glaucoma developed other de novo eye disorders in the first month of treatment. Comparatively, nearly half of the patients without previous ocular pathology developed ocular symptoms linked to the treatment at 3 months. OAB treatment influences the appearance of de novo eye disease. It is minimal after Botox treatment and more frequent with anticholinergics. Not only blurred vision and high intraocular pressure could be suffered in patients treated with anticholinergics, but other ophthalmological disorders may also appear, like dry eye and recurrent conjunctivitis. The risk was higher with solifenacin than with the other treatment. In Group A, there was a higher risk of developing de novo eye disease when patients were treated with solifenacin, fesoterodine, oxybutynin, and mirabegron. Conversely, in Group B, the risk was lower with oxybutynin, solifenacin, and tolterodine. In the group of patients with previous glaucoma disease, no treatment showed an statistical significant influence of the appearance of de novo ocular pathology. There was a trend towards recommending pelvic floor muscle training in patients diagnosed with glaucoma. Those patients without previous eye disease were more frequently treated with mirabegron, Botox, solifenacin, and oxybutynin, and those with other eye disorders, excepting glaucoma, received more frequently fesoterodine and tolterodine. The study reflects that the ophthalmological health status of the patient influenced the election of OIB treatment, being glaucoma the most considered eye disorder when prescribing anticholinergics. In patients with no pathological background, maybe other pathologies like diabetes could influence OIB treatment. We conclude, after 3 months, nearly half of the women suffered dry eye or de novo conjunctivitis, especially if they have no previous ophthalmological problems. These disorders appeared sooner with oxybutynin and later with fesoterodine and mirabegron. In patients have previous ocular pathology other than glaucoma, all OIB treatment favored dry eye and conjunctivitis, but they were more frequent with solifenacin. Thank you for your